So, madam, we are live now and we are starting the program. So, good evening, doctors and all the participants. Ishumon on behalf of Shield Healthcare, welcome you all in today's session, that is stress and infertility. And our guest speaker is Dr. Poonam Mishra, madam. So it's my honor to introduce Madam. Madam is the president of Indian School of Aesthetic Gynecology. She is the chairman of Cosmetic Gynecology, ISAR and SIG. Madam is a member of Sexual Medicine Committee, Foxy India, and Madam is the present director of Manas Hospital, Manas Gynae Cosmetology, and Laser Center and Miracle Aesthetic Clinic, Lucknow. Madam is presently practicing obstetrician and gynecologist with special interest in cosmetic gynecology, regenerative medicine, and sexual health. And in terms of academic activities, Madam organized many conference, national and international conferences, and she also participated on that and given many lectures on. So with the short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the drop box of our chat box so that after the session we can have a small discussion on this very important topic, that is stress and how this stress is related to this infertility. So thank you very much, Madam, for your valuable time to spend on this very important topic on our platform Shield Connect, and over to you, ma'am, for further proceedings. So thank you very much.
Thank you so much. Thanks a lot for this nice introduction and generous introduction also. So I am here as I have been introduced, Dr. Poonam Mishra, and I run a very small hospital, Manas Hospital at Lucknow, and I am very much keen. I have been very passionate about the subject. Gynae cosmetology, which is very much in vogue, and gynae cosmetology, aesthetic gynecology is something which is a very upcoming, futuristic, and this is the future, the new bud of gynecology, I mean to say. And as you know, infertility has always been sharing a very vast majority of our practice, gynae and obs. And there also, what is the reason? What could be the reason for this infertility? Has always been a matter of controversies and a matter of something to be explored a lot. And that is why I'm very happy that I have been given this topic today. So I would be sharing a few like data as well as whatever is there regarding stress and infertility. So let's start our presentation, and without wasting any time, let's go for the presentation. So it is stress and infertility we are going to talk about. I think there is. Yes. So stress plays a very something very bulky, very like huge role in the precipitation of infertility in a couple. Why? We are going to just discuss. New epidemic of young India is infertility. Yes, in our practice, I can say that many times, like if you are having an OPD of 40 to 50 patients per day, every day there are 10 to 20 patients of infertility. This is our day-to-day practice, and this is our experience. Whatever data say, that is something different. But yes, we all know that infertility has been a major part of our practice. So India faces a high burden of infertility, with 22 to 33 million couples in reproductive age suffering from lifetime infertility issues. 1 in every 4 couple, that is 25%. Yes, you can see here. 1 in every 4 couple in the reproductive age in India struggles with infertility. More than 1 young Indians are finding it hard to conceive. At least 10 to 15% of married couples are experiencing fertility issues, and 40 to 50% of the cases are attributed to problems with women, while for the rest, it is men, about 30 to 40%. See how huge is the part of infertility in our practices. surprising fact is that male infertility in India is on a rise with every passing year. Yes, this is becoming very, and in our practice, we had never used to ask about the male sexuality disorders. And now I have my experience is that whenever an infertile couple is there, and when you start talking about the reason of their infertility, why, what is the problem, what is the main cause, and there you will get that the male is suffering from some sort of erectile dysfunction or some premature ejaculation, and many things are there which have never been used to be in our practices earlier, and they are being precipitated these days. And that is why the male infertility is also on a pattern of is on the rising pattern. So factors have impacted the infertility rate in India. Yes, many factors are there, and these are some unexplained ones, and the female factor combined and male factor. And here you can see that female factor is 40% and the male factor too is 40%. Unexplained and combined play take just 10% of parts. So the factors could be the unhealthy eating habits, PCOS, others, older couples, because yes, because of their career building, the marriages are getting late and late, and so the couples are in their older ages, and that is why the fertility is decreasing in their in them, and that is why the infertility is there with these couples. So stress plays a major role, and our lifestyle, our getting late marriages, our being worried for the career, these all play major roles in the precipitation of these factors. So being diagnosed with infertility, everyone reacts to the diagnosis of infertility differently. Diagnosed parents, partners can experience several emotions like shock, surprise, or denial, a sense that the diagnosis is not really true. This can also be described as feeling numb or not knowing what to do. Anger and frustration. This can be expressed as why is this happening, or feeling angry at others. Many times they say, why us? What have we done wrong? We were busy. We have always been very good human being. We had no bad habits, nothing. We are just, the factor is that we were career oriented, or something, some problem is there in their families, some problems with their combined families, some problem with their privacy, spaces, less spaces are there in the families these days. You know, people are living in 1 or 2 bedrooms flats, single studio flats are in vogue. So the privacy issues are also there, and there they are absolutely stunned that what is this? We are infertile, we are having some problem. So anger and frustration, this can be expressed as why is this happening to us, or feeling angry at others. Anxiety, fear, or panic, all thoughts are very confused. Isolation, feeling different from others, sense of loss. There are many aspects of grief covering loss of pregnancy, motherhood, and fatherhood. These can continue through all stages of infertility. So can stress be a contributing factor for infertility? This is the question. This is the topic of today. Yes, stress affects fertility, but people were unable to discover why and what and to what extent. And stress and infertility, they are quite intricately woven together. Link between stress and reproductive dysfunction has been well established. Psychological stress experienced by female or male partners of infertile couples has been associated with lower conception rates. Data from animal models suggest psychological stress may be a major contributor to both male and female infertility. Stress can compromise every aspect of fertility, including libido, sperm quality, ovulatory capacity, and implantation. We can see that each and every step of infertility is being affected by this stress content. So stress influences reproductive function at all levels. Stress can interfere with reproductive function at all levels of the reproductive axis. It can suppress libido, reward, and mating behavior at a level of brain, particularly the ventral tegmental area. You can see here. And it interferes with the hypothalamic gonadotropin releasing hormone, GnRH pulse generator, and luteinizing hormone and follicle stimulating hormone release from the anterior pituitary. It suppresses oocyte maturation, ovulation at the level of gonads, as well as increasing the likelihood of ovarian cyst and affecting both ovarian and testicular steroidogenesis. Stress is also detrimental to pregnancy outcomes post-conception. So not only the infertility, somehow if after the treatment, the couple gets pregnant, the lady gets pregnant, it is going to affect the pregnancy outcome also, reducing the likelihood of successful blastocyst implantation. So the hypothalamic pituitary adrenal axis. Upon encouraging a stressor, medical parvocellular corticotropin releasing hormone, CRH, and arginine vasopressin neurons of the hypothalamus receive inputs from several brain regions, including the amygdala, brainstem, and prefrontal cortex, and stimulate CRH release into the median eminence. CRH acts as the anterior pituitary on the anterior pituitary through CRH receptor type 1, leading to the release of adrenocorticotropin hormone, ACTH, into circulation, a peptide hormone derived from pro-opiomelanocortin. ACTH stimulates glucocorticoid release to regulate glucose and fat utilization and storage, memory, immune function, and other stress coping strategies, as well as negatively feeding back on glucocorticoid and mineralocorticoid receptors in the hypothalamus and hippocampus to suppress further HPA axis activation. So in a nutshell, it gives negative feedback. Hypothalamic medial preoptic area, kisspeptin, KIS1, neuron stimulates and gonadotropin inhibitory hormone neurons inhibit gonadotropin releasing hormone pulsatile release into the median eminence. GnRH release stimulates the release of gonadotropin luteinizing hormone LH and FSH from the anterior pituitary. This in turn leads to the release of ovarian steroids, mainly estrogen and progesterone, and that can carry out both negative and positive feedback actions depending on the stage of the ovarian cycle. In males, gonadal release of testosterone produces inhibitory actions on GnRH gonadotropin secretion. There is negative feedback. And pituitary gonadotropins also stimulate steroidogenesis. So intersection of HPA and HPG axis. Corticotropin releasing hormone can directly inhibit the gonadotropin releasing hormone pulse generator, leading to suppression of pituitary gonadotropins, luteinizing hormone, and follicle stimulating hormones, in turn releasing in diminished oocyte maturation and steroidogenesis. And so, the same way, glucocorticoids can act directly at the level of pituitary to suppress gonadotropin levels, as well as to exert suppressive effects within the gonads. CRH release from the paraventricular nucleus of the hypothalamus activates locus ceruleus neuron, increasing noradrenaline production. So this stress-induced increase in sympathetic activity can then increase sympathetic innervation of the ovary, contributing to the development of ovarian cysts. So what studies say? Studies are there in which there is evaluation of predictor factors of psychological distress in women with unexplained infertility. There has been a study which very clearly says that with unexplained females with unexplained infertility, and for the treatment there should be developed to better support and treat this high risk population. Depression and emotional stress is highly prevalent among women with recurrent pregnancy loss. See, the recurrent pregnancy loss is also being affected by or caused by this uh, uh, this stress, and it has been found that the prevalence is more. See, study question is the prevalence of psychological stress and moderate severe depression higher for women with recurrent pregnancy loss, RPL, than pregnancy planners trying to conceive naturally? What is known already is recurrent pregnancy loss has a significant emotional impact on couples, especially the women. Previous studies have shown inconclusive results. And finally, what we get that this study should entail a heightened awareness of mental distress among care providers for women with RPL. So in our day-to-day practice also, when these patients are increasing in their number, our behavior and our practices should be directed towards this side of like case discussion also, and to rule out the stress and other factors, detrimental factors, which are causing infertility, then difficulty in conception, and then in somehow if she has conceived, for recurrent pregnancy losses. Another study, the investigation holistic stress of infertile women and relation to demographic characteristics in women who referred to Yas Infertility Center. Here also, it has been found that infertility has a significant impact on the infertile women's mental health. Another study in Middle East Fertility Society Journal, it was found that 22% of infertile patients in the clinic experience stress mainly associated with the duration of their infertility. In women, what kind of effect is there with stress? Stress-induced anovulation. So common causes of anovulation or amenorrhea is, the number one is a stress-induced anovulation, functional hypothalamic amenorrhea, which actually takes the 34% of the part of infertility, and rest, the PCOS, the hyperprolactinemia, premature menopause, Asherman syndrome, and other factors have got the smaller parts. So how stress affects ovulation? How come? When a person is under chronic stress, the HPA axis is activated, which leads to increased levels of cortisol and corticotropin releasing hormone, as we saw in the previous slides. The whole mechanism of release of cortisol, and cortisol is something, the black hormone is there. The increased cortisol and corticotropin releasing hormone can suppress the normal levels of the reproductive hormones, which can potentially lead to abnormal ovulation, anovulation, and amenorrhea. How stress affects ovulation? Again, when there is a presence of adequate estrogen levels and there is stress-induced activation of HPA axis, the higher amount of LH is released. This is the counter factor of the counterfeit of the stress in our body. Studies have found that the increase in LH was most probably associated with the increase in adrenal progesterone, should feed back negatively on the gonadotropins in the pituitary to reduce LH that accompanies the release of the estrogens in response to the stress. It has also been reported that progesterone can stimulate LH secretion by acting directly on the pituitary. Because of the stimulation of the LH secretion, this may provoke a premature LH surge and thereby interfering with the follicular maturation and ovulation. Furthermore, elevated LH concentration at different stages of the menstrual cycle may have conflicting effects on the maturing follicle and on the developing oocyte, and may result in early pregnancy loss due to the egg not implanting properly. And so impact of stress on oocyte quality and reproductive outcome. See here, the stress is causing the premature the increased cortisol as well as oxidative stress levels affect granulosa cell functions, possibly by inducing apoptosis. The granulosa cell apoptosis results in reduced estradiol 17 beta biosynthesis in the ovary, which reduces growth and development of follicular oocytes and induces oocyte apoptosis. Apoptosis deteriorates oocyte quality, leading to poor reproductive outcome in mammals, including humans. So the oxidative stress itself releases the black hormone, the cortisol, and that cortisol is responsible for all sort of negative factors related with the fertility. So list of studies showing effect of stress on ROS production and oocyte quality. Stressful life events cause release stress hormone and impair follicular maturation in ovary, human. And second, so these are some studies, and they have found that many studies are there which are directly telling that the stress has straightforward affected the follicular maturation. So stress and endometrial receptivity. Here also we are the human endometrium plays a vital role in providing the site for embryo implantation and maintaining the normal development and survival of the embryo. Recent studies have shown that stress is a common factor for the development of unexplained reproductive disorders. The non-receptive endometrium and disturbed early maternal-fetal interaction might lead to infertility, including the repeated embryo implantation failure and recurrent spontaneous abortion or late pregnancy complications, thereby affecting the quality of life as well as the psychological status of the affected individual. The impact of stress on human endometrium. You can see here directly that the whole human endometrium is dysfunctionally developed, and in the same way as we were discussing in the previous slide. Lower GnRH level, lower FSH, LH, altered secretion of estrogen and P4, inhibition of the epithelial and stromal cell proliferation, inhibition of the stromal cell differentiation, altered endometrial gene expression, impaired endometrial receptivity, affected embryo implantation and development. This all is affected by the stress directly. In males, what happens in males? According to the American Society of Reproductive Medicine, the infertility affects men and women equally. And semen quality is a key indicator of male fertility. Men who feel stressed are more likely to have lower concentration of sperms in their ejaculate. And the sperm they have are more likely to be mishappen or have impaired motility. Some sort of, like the quality is also affected directly. It may trigger the release of steroid hormones called glucocorticoids, which in turn could blunt levels of testosterone and sperm production. Another possibility is oxidative stress, which have been shown to affect semen quality and fertility. So persons having abnormal HEDS had lower serum total testosterone, higher serum FSH and LH than those of persons having normal HEDs. Effect of psychological stress on fertility hormones and seminal quality in male partners of infertile couple. The study is there. And it is clearly showing that sperm count, motility, and morphologically normal spermatozoa were lower in persons which were suffering with the stress. The effect of emotional stress on sperm quality. Male patients with idiopathic infertility were selected after evaluation of psychological stress to evaluate a positive effect of a stress therapy on their semen quality. Data showed that necrosis and apoptosis were higher, and the number of healthy sperm was significantly reduced in both groups of stressed men compared to reference values. The number of healthy sperms was significantly higher in the treated group after therapy. indicating a recovery of sperm quality. The effects induced by stress also seem to include meiotic and structural alterations in sperm cells. The main alterations in sperm pathologies were related to apoptosis and necrosis. Marginated chromatin and solin and badly assembled mitochondria were the typical ultrastructural marker of apoptosis, and reacted or absent acrosomes nucleus with disrupted chromatin and broken plasma membrane were signs of necrosis. Here also the relationship between psychological stress and reproductive outcome in women undergoing in vitro fertilization treatment, psychological and neuro hormonal assessment. So here the abstract was the purpose to evaluate whether psychological stress as well as changes in hypothalamic pituitary adrenal axis and sympathetic nervous system at different time points during a first in vitro fertilization cycle correlates with the reproductive outcomes. And it was found that yes, the conclusions state anxiety is associated with both pregnancy rate and live birth rate in IVF patients, an effect that is partly mediated by activities in the HPA and SNS, sympathetic nervous system. Again, the conclusion is rates of stress, anxiety, and depression among IVF patients are higher than in general population. Yes, because they know that they are infertile to a significant level. That is why they are there for the IVF, and their stress level is high. And with that, the other factors which are leading to the implantation failures and other IVF success rates. The prevalence of depression symptoms among infertile couple, a systematic review and meta-analysis. Another study which states that the prevalence of depression among infertile women was higher than that among the general population of a given country, especially in the low and middle income countries. Appropriate measures, planning, and policy that target the negative effects of depression on infertile women's lives should be established to reduce the related problems. So in the same way, here again, stress management during the intracytoplasmic sperm injection cycle may slow down first embryo cleavage and accelerate embryo compaction. A pilot randomized control trial here also, and this is also saying the direct relationship with the impact of stress on fertility. Infertile patients respond to the stress of being unable to conceive by aggressively pursuing treatment and procedures. Patients withdraw and isolate from family, friends, and community. Most people who cannot get pregnant have an actual physical explanation, but as month after month goes by, feelings of stress, anxiety, and depression often kick in. So it's a vicious circle. Patient is depressed and her fertility is affected. Fertility is affected, again she is depressed. So it's a vicious circle and the process goes on and on. Even if the physical cause of infertility is treated medically, surgery for endometriosis, example surgery for endometriosis, problems with low sperm count and others, it's possible that high levels of stress can still make getting pregnant more difficult. Infertility causes stress, which is aggravated as time passes, and the couple remains infertile. Couples participating in an IVF program are highly stressed, especially after a failed IVF cycle. So stress because of IVF procedures. There is another sort of stress part. Taking time off from work for doctor appointments, having blood drawn, having pelvic examinations, multiple examinations, ultrasounds, injections, timing intercourses, because a person is not natural. A person is not allowed for the natural course of coziness. And various diagnostic procedures, cost factor, they all are going to impact on the stress factor. Efficacy of the reduction of stress before fertility in treatment commences. There are evidence that personality dimensions, coping modes, stress susceptibility, and resilience correlate with IVF outcome. It is always there. Recent studies indicate that stress increases the dropout rates from treatment. Psychological interventions such as behavioral treatment aimed at reducing stress in IVF have shown to be effective in several studies. A recent meta-analysis showed that psychotherapy accompanying IVF also is effective. Short-term goals for male and female fertility patients. Short-term goals are a reduction of feelings of helplessness through coping with infertility, changes in sexual behavior, modification of negative cognitions as to infertility, overcoming deficiencies in knowledge about fertility, and improving marital communication skills. So two main factors appear in chronic stress that determine what influence the psychological conditions and mood state in a couple on their fertility treatment. The first factor is the way in which the person handles stressors in general. If that coping way is less than adequate, stress may become chronic, and chronic stress affects fertility. अगर ज़्यादा stress overcome करने लगेगा, तो fertility पे सीधे असर पड़ने लगेगा. The second factor refers to how the person handles the threat to her or his self-esteem or her or his biological and social value, which results from the knowledge that something is amiss with her and or his fertility. As a result, anxiety and altered mood states in general are common for the moment doubts as to a couple's fertility arise and increases sharply. The clinical relevance of this second factor is well established and is up to now the one factor that fertility treatment sometimes take into account and will try to control with psychological approaches. However, more and earlier attention should be paid to the first factor, as chronic stress is an important influence on treatment outcomes. Religious and social beliefs could be considered markers for fertility-related stress in their own right. So here again, establishing stress levels before fertility treatment. A physician other than the fertility clinic specialist, often the gynecologist, usually makes a preliminary diagnosis of infertility. This physician should establish stress levels with the help of validated questionnaires or refer to a psychologist for this purpose to see if there is reason to suspect that chronic stress plays a significant role. How important this stress factor is in the treatment of infertility. His findings will not yet be affected by the additional stress produced by visits to a fertility clinic. If indicated, stress reduction techniques should be applied, and after 3 months, stress levels should again be measured with the same questionnaires. The couple is then referred to the fertility after the management of the stress. The fertility clinic again establishes stress levels, this time both psychological and biological, and compares findings with the previous uncontaminated measurements to determine the susceptibility to stress treatment. If levels are still over established individual thresholds, another 3 months of stress reduction is attempted before going for any IVF procedures. When stress reduction is obtained, fertility treatment is initiated with the concurrent stress management for both. If stress levels remain over established thresholds, the couple should be advised on the increased probability of a negative result of the fertility treatment and should be recommended to continue with therapy until lower stress levels are attained. However, if they insist, an informed consent should be signed. So with this discussion, we can actually get to the point that how important the stress management is. Even the stress should be managed beforehand, before going for the treatment of infertility. So here, establishing stress levels before fertility treatment. Diagnosis of infertility establish male and female chronic and acute stress levels with validated questionnaires. Then, if over thresholds, intensive stress reduction techniques for 3 months, establish stress levels and referral to fertility clinic, establish male and female chronic and acute stress levels again with psychological and biological analysis. If over thresholds, intensive stress reduction through psychological and adjuvant dietary treatments for 3 months. And if reduction is obtained, then only the initiation of fertility treatment with concurrent male and female stress management should be there. Several studies present promising results of psychological interventions leading to higher pregnancy rates. State anxiety has considerable validity as an independent marker for better pregnancy rates on account of the effect of anxiety on the implantation period of the fertility cycle. To improve overall pregnancy rates is not simply a matter of reducing acute stress, but rather of finding ways to improve the efficiency of the adaptive response to stressors. So what are the interventions which control for stress control and fertility treatment? Procedure means protocols to include patient selection according to existing chronic stress, preliminary treatment to reduce anxiety and depression, psychological means cognitive behavioral therapy, relaxation training, differential orientation as to infertility, fertility sabbatical permit, technical means frozen backup semen samples taken at low stress moments outside the fertilization cycle, further refinement for fertilization techniques such as removal of the acrosomes before XC, and neurobiological means establishing individual baselines and specific stress makers, establishing thresholds for referring and monitoring for stress before and during fertility treatment. So see, every heading has got the different definitions. Ethical and technical reasons for stress management before fertility treatment. Presently available evidence support the following 3 assertions. Infertility causes stress in the couple involved. Infertility treatment causes stress in the couple involved. Stress may be a primary or secondary cause of infertility itself. As I said, it's a vicious circle. For each, the level of evidence is different. The first 2 having been repeatedly confirmed by acceptable studies, whereas the third is supported by a number of studies that are acceptable in design and execution and should be taken as probable yet not conclusive evidence. Stress management. No one expects patients to approach fertility treatment stress-free. Finding ways to minimize the stress while pursuing treatment can help, actually can help. Ways to reduce the stress. Just a moment. So how can we reduce the stress? Talk to your partner. Remember, you are not alone. Talk to people with infertility through individual or couple counseling or support groups. Read books on infertility, which will help you to be normal and can help you deal with stress. Stress reduction techniques such as meditation, yoga, progressive muscle relaxation, or acupuncture. Avoid taking too much caffeine or other stimulants. Exercise regularly to release physical and emotional tension. These are the ways we can advise the patients to get rid of their stress or to reduce their stress level. Safe and effective supplements that can reduce the levels of serum stress hormones, that is cortisol and adrenaline, can boost the fertility and increase the chances of becoming pregnant. And here comes the role of pharmacotherapy. So these days we are getting this newer molecule, ORAA. They are having lactium 150 milligram with L-theanine 100 milligram, which relieves stress and anxiety, normalizes cortisol level, improves reproductive function, and improves fertility outcomes. So lactium, how does it work? Lactium on hypothalamus, it reduces the cortisol releasing hormone, and on pituitary gland, it reduces the action of adrenocorticotropin hormone for the release of adrenaline through the adrenal glands. Adrenal cortisol, the cortisol, adrenal cortex, the cortisol is decreased, adrenal medulla, the adrenaline is decreased. So 25% reduction in stress-induced cortisol level within 3 hours has been seen with the help of the therapy with lactium. Lactium reduction of stress-induced cortisol levels regulates GnRH pulsatile, pulsatility, normalizes LH and FSH ratios. And in females, it normalizes estrogen production, improves oocyte quality, normalizes progesterone production, and in males, normalizes testosterone production, normalizes spermatogenesis process. So lactium, what does it do, what it is, how does it work? Selectively binds to omega-2 GABA receptors, improves GABA activity, no binding to omega-1 GABA receptor, and so there is no sedation. L-theanine, a natural constituent in tea, and its effect on mental state. Evidence from human electroencephalograph studies show that it has a direct effect on the brain. L-theanine significantly increases activity in the alpha frequency band, which indicates that it relaxes the mind without inducing drowsiness. So the benefits in stress of these products, the L-theanine as well as the lactium. It regulates hormones pathway, reduced stress, induced cortisol and adrenaline. It regulates neuronal pathway, increased GABA and decreased glutamate activity. It improves coping mechanisms, and it causes improvement in alpha waves, good quality sleep. So it improves fertility outcome with the help of these pathways, which regulates GnRH and gonadotropin, which regulates estrogen and testosterone. It regulates oogenesis and spermatogenesis, regulates progesterone, improved endometrial receptivity, and it regulates libido also. So here we are seeing that no sedation is there, tolerance is like not up to that one, that the effect is gone, no withdrawal symptoms, no addiction. What is the take-home message with all these slides and this discussion is that we know that infertility can cause stress that leads to anxiety and depression. Stress can make conception more difficult for men and women. Stress reduction techniques, when employed on a regular basis, can improve conception rates. Stress reduction is a non-invasive, less expensive, and ethically acceptable way of improving fertility. Fertility treatment protocol should include stress management and stress reduction as factors of major importance. The professionals in reproductive medicine should always test for chronic stress before initiating fertility treatment and adjust selection and treatment protocol accordingly. Thank you very much. So I hope even I found that discussion very fruitful, and I could get the message that yes, that stress is playing the major role in fertility management. So
Thank you very much, ma'am, for this nice presentation on this stress and infertility, how it is related to infertility specifically. Just we'll wait for 1-2 minutes to take the questions. But meanwhile, I have one question, ma'am. Just few days back, I was going through a research article, and that research article, the title was that should infertility treatment start with reducing stress? So what is your thought on that particular aspect? How the infertility treatment should be should move forward for this?
See, an infertile couple, after thinking a lot, comes to the clinician. It takes a long time for an infertile couple. They not always, you will find in your clinics, like I am talking to our friends, the delegates, the attendees, that in our clinics, they take a long time to report to their gynecologist or to their infertility management person. And there you can very well judge that, yes, the stress component is too high in these infertile couples. So according to me also, the stress management should be considered first before straightforward starting any treatment for the infertility.
Thank you very much, ma'am. And one question is, ma'am, that is, as in infertility treatment, there is lots of medications and some other things are also there, and that is also causing stress to the particular patients.
Exactly. Yes. Yes. This, in our discussion also, in our slides also, we could see that reporting to the infertility treatment giver and then going through all those examinations, and then the prescription of different medications, their cost, their feeling that gives them a feeling that they are not from the normal population. They are suffering a lot and they need a lot of treatment. That all is causing stress directly. So this is a vicious circle. And the infertility leads to stress factor further leads to the infertility. That is why, yes, it is absolutely correct that medications, multiple medications, the need of the therapeutic agents, the need of multiple therapeutic agents, they all cause stress to these infertile couples.
Thank you very much, ma'am. And what is your practical opinion, ma'am? Should all the treatment to all the patients must be with this approach to this stress condition, or is there any parameter? So in that particular area, we can focus on the stress, or on that particular patient, so we no need to bother the stress condition. Is there any practical observation or practical scenarios?
See, actually, in our OPDs, we are so busy with our patients. We are dealing with the number of patients in a limited time factor. So we don't go much deeper into their histories. We are just confined to their infertility part, and that is why it is not easy to get out from them the factors which are leading to infertility. Exactly. We are just going through the infertility management. But what I told you, that recently I have started giving time to our patients, to my patients, and then I realized that many of them need maximum of counseling only. Many patients are relieved with proper counseling, proper guidance. And in my opinion, 80% of infertile couples are actually treated with some initial management and with the proper guidance, with the proper counseling only. Only 20% is the part which needs vigorous treatment or needs IVF, in vitro fertilization techniques actually.
Thank you very much, ma'am, to discuss such a wonderful topic and in such a nice way in your practical. Thank you for sharing your practical observation also in terms of this infertility condition. So thank you very much, ma'am, for your valuable time once again on our platform Shield Connect. And in future also, I will look forward for some valuable session with you, ma'am. So thank you very much. Yes.
And thank you so much to you all, the Shield people, for giving me this opportunity to be here with this august audience. Thank you so much.